Hello everyone, welcome to another warm-up. Let's get going. During which weeks of fetal development does organogenesis take place? Remember, it's weeks 3 to 8. Next, which group of genes is responsible for skeletal development? So remember, it's the HOX, H-O-X genes. Next, what is required for a molecule to enter into the nucleus through a nuclear pore? Well, nuclear localization signals are required, which are 4 to 8 amino acid sequences that are rich in things like lysine, arginine, and proline. All right, guys, that brings us to the end of the warm-up. Let's get to the lecture.
Welcome to Cranial Nerves Part 2, the much anticipated sequel to the smash hit Cranial Nerves Part 1. In this video, we're going to finish the rest of the cranial nerves, starting with cranial nerve 5. Cranial nerve 5 is the trigeminal nerve, which has 3 divisions: the ophthalmic branch, the maxillary branch, and the mandibular branch. Now, the first 2 branches are purely sensory, while the mandibular branch has both sensory and motor functions. The ophthalmic branch exits the skull at the superior orbital fissure, the maxillary branch exits the skull at the foramen rotundum, and the mandibular branch exits at the foramen ovale. Now, in terms of function, the ophthalmic branch provides sensation to the forehead and down the bridge of the nose. The maxillary branch provides sensation to basically from the eyes down to the upper lip, and then also the lateral part of the nose, as well as the nasal mucosa and the palate and the upper teeth. And then the mandibular branch provides sensation to the jaw and extending in front of the ears all the way up to the temples. It also provides touch sensation to the anterior 2/3 of the tongue, but not taste sensation. Taste sensation is provided by the facial nerve and the glossopharyngeal nerve primarily. And the mandibular branch also provides motor innervation to the muscles of mastication, which we'll get to in a moment. But while we're talking about the sensory functions of the trigeminal nerve, let's talk about how we test the trigeminal nerve. So you can test for pinprick or light touch on all 3 regions of the face. You can also test some cranial nerve reflexes. So you can test the corneal reflex by touching the cornea gently with a wisp of cotton, see if that makes the patient blink. So that's going to test the ophthalmic division of the trigeminal nerve, and it's also going to test the temporal branch of the facial nerve, or cranial nerve 7, because that's what provides the motor innervation to the eyelids. We'll talk about that in a moment. So the corneal reflex is testing 2 cranial nerves, cranial nerve 5, the ophthalmic branch, and cranial nerve 7, the temporal branch. Then there's the lacrimation or tearing reflex, which also requires function of the same 2 nerves. So cranial nerve 5 is going to sense the pain if you touch the cornea, and then cranial nerve 7 is going to produce the tears. But lacrimation reflex is really not one we usually test. And then compression of the trigeminal nerve is going to cause trigeminal neuralgia, which is a shooting electricity-like nerve pain on the face. And it's usually very difficult to treat. It's usually due to compression of the trigeminal nerve root near the pons. And we also said that the mandibular branch provides motor innervation to the muscles of mastication. The masseter, the temporalis, and the medial pterygoid are all responsible for closing the jaw. And then the lateral pterygoid is the muscle that opens the jaw. And you can test that motor innervation by asking the patient to open the jaw against resistance, or maybe just have them clench their teeth while you're feeling the temporalis muscle and the masseter muscle. So that's it for the trigeminal nerve. But before we move on to the facial nerve, let's talk about the cavernous sinus, because the first and second divisions of the trigeminal nerve run right through the cavernous sinus. Other nerves that run through the cavernous sinus include the oculomotor nerve, the trochlear nerve, and the abducens nerve. And other important structures nearby include the internal carotid, the pituitary gland, the optic chiasm, and the sphenoid sinuses. So if there's an infection in this so-called danger triangle, that infection can spread to the cavernous sinus and lead to cavernous sinus thrombosis, blood clotting in the cavernous sinus. And this can lead to cranial nerve palsies and also pain or numbness from compression of these branches of the trigeminal nerve. So be aware of that. Cranial nerve 6 was covered in another video, so now let's move on to cranial nerve 7, which is the facial nerve. The facial nerve exits the skull through the internal acoustic meatus, along with cranial nerve 8. Because remember, when we looked at the cranial nerves coming off the brainstem, both cranial nerve 7 and 8 came off the posterior pons together, so they're going to exit the skull together. Now, there are 5 branches of the facial nerve: the temporal branch, zygomatic, buccal, marginal mandibular, and the cervical branch. And there are several different mnemonics for these, like 2 Zanzibar by Motorcar or 10 zebras bit my chin. The big function of the facial nerve is motor innervation of the muscles of facial expression, as well as motor innervation of the stylohyoid muscle, the posterior belly of the digastric muscle, and also the stapedius muscle in the middle ear. And remember, all of these structures are derived from the second branchial arch. So S for second arch, S for cranial nerve 7, S for stylohyoid, and so on. And we've already alluded to some of the other functions of the facial nerve. In addition to the motor function, it provides parasympathetic innervation to the lacrimal glands to cause tearing. It also innervates the submandibular glands and the sublingual glands, which make saliva. The parasympathetics tend to make things leaky, lacrimation, salivation, and so on. And the facial nerve passes through the parotid gland, but it does not actually innervate the parotid gland. So it causes salivation, but not salivation from the parotid gland. Submandibular glands actually produce more saliva than the parotids do anyway. We also said that the facial nerve provides taste sensation to the anterior 2/3 of the tongue. Now, to test the facial nerve, we're mostly testing the motor function by having the patient wrinkle up his forehead or raise his eyebrows or furrow his eyebrows or puff out his cheeks or close his eyes tightly while you're trying to stretch the eyes open. So lots of different tests for the facial nerve. So imagine on your exam, they give you a patient with a unilateral facial weakness. The patient may present with relatively acute onset of facial droop, where the right side of the mouth seems to sag, or the right eye won't open or close all the way. When you ask the patient to smile, the smile is clearly asymmetrical. So maybe you do some of those facial nerve tests, like have him puff out his cheeks or keep his eyelids shut while you try to force them open, and clearly the right side of the face is weak. Well, since we're talking about cranial nerve lesions, you're probably thinking that's a right facial nerve palsy, and you may be right. A unilateral facial nerve palsy, or facial nerve nucleus lesion, will cause this unilateral facial droop. And the term you may hear for this is Bell's palsy. Now, technically, Bell's palsy is only supposed to be idiopathic facial nerve palsy, but lots of things can cause a facial nerve palsy. So one mnemonic for these is Lovely Bella had an STD. So the L in lovely is for Lyme disease. The Bell in Bella is for Bell's palsy, which is, again, idiopathic facial nerve palsy. The H in had is for herpes simplex and also herpes zoster. The A in an is for AIDS. And then the STD is for sarcoidosis, tumors, and diabetes. Now, of all of these, herpes simplex virus is probably the #1 cause of what gets diagnosed as idiopathic Bell's palsy, because we don't really have a great way of detecting or diagnosing HSV in these patients. So I wouldn't get too hung up on whether or not something is really true idiopathic Bell's palsy. In practice, we tend to call any unilateral facial palsy Bell's palsy, and then say it's Bell's palsy secondary to Lyme disease or herpes simplex or whatever. But when that patient comes in with unilateral facial weakness, the other big thing you have to worry about is an acute stroke. Bell's palsy is pretty benign, and it's usually going to be self-limited. We usually give steroids like prednisone for a week or so, but these patients are usually going to recover within about 3 weeks. But a stroke is another matter entirely. You need to be able to recognize an acute stroke and treat immediately. The next question in your study guide says, how do the symptoms of a facial nerve or facial nerve nucleus lesion differ from the symptoms of a facial motor cortex lesion, like a stroke? Well, a facial nerve lesion, like in Bell's palsy, will cause paralysis of the ipsilateral side of the entire face. So if you knock out the right facial nerve, all the facial muscles on the right side of the face will be paralyzed, and the patient will have facial droop on the right. But a facial motor cortex lesion, like a stroke, will result in paralysis of the contralateral side of the face, and only the lower face. The contralateral part probably makes sense because you know that the right side of the face is controlled by the left motor cortex. But why does a stroke not affect the upper face? Well, look at the next question. The facial motor nucleus receives motor fibers for the lower face from the contralateral motor cortex, but it receives motor fibers for the upper face from both motor cortices. In a left motor cortex stroke, only the right lower face will be paralyzed because the right upper face still receives innervation from the right motor cortex. But since the left motor cortex is the only cortex that innervates the right lower face will be paralyzed. So, if a patient comes to the ER complaining of facial droop on the right side, you need to quickly determine if this is a stroke or just acute Bell's palsy. And the forehead is going to be a big help to help you determine this. If the forehead is paralyzed along with the lower face, then you're probably dealing with Bell's palsy. But a stroke will only affect the lower face. So you're going to be sure to examine whether or not the patient can move his eyebrows. If the patient comes in with facial paralysis, but he can still move his eyebrows, then you need to get moving because this is probably a stroke. The next cranial nerve is cranial nerve 8, the vestibular cochlear nerve. Now we already said that this exits the skull through the internal acoustic meatus along with the facial nerve. It's responsible for both equilibrium and hearing, and you can test it by testing hearing and also by looking for nystagmus and balance problems. And then the next nerve is the glossopharyngeal nerve, which is cranial nerve 9. Glossopharyngeal nerve exits the skull through the jugular foramen, along with cranial nerve 10 and cranial nerve 11. Cranial nerve 9 is one that has a ton of different functions. It provides motor innervation to the stylopharyngeus muscle. It provides parasympathetic innervation to the parotid gland to make saliva. It sends branches to the carotid sinus to measure the blood pressure, and also branches to the carotid bodies to measure blood chemistry. It also provides sensory innervation to the pharynx and to the back of the tongue, and taste sensation to the posterior third of the tongue. It's the glossopharyngeal nerve, so the sensation of the tongue, sensation of the pharynx, it's going to be pretty easy to remember. And then one way you can test the glossopharyngeal nerve is by checking the gag reflex, which also happens to test vagus nerve function. Next is cranial nerve 10, the vagus nerve, which again, it's going to exit the skull through the jugular foramen. The functions of the vagus nerve include motor innervation of several pharyngeal muscles involved in swallowing and elevating the palate, and also innervation of the larynx. So swallowing and speaking require a functional vagus nerve. The vagus is also one of the body's main parasympathetic nerves, so it carries parasympathetic signals to the heart and to the GI tract. It also provides sensory innervation to the pharynx and the trachea and the esophagus, so irritation of the vagus can trigger coughing. And it provides a taste sensation to the very back of the tongue. Now, testing the vagus nerves usually involves having the patient elevate the palate by saying ah. But you can also check the gag reflex, and you can listen to the voice quality. That's going to tell you if the laryngeal muscles are working properly. Now let's look at the question in your study guide that says, if the right vagus nerve or nucleus is damaged, to which side will the uvula deviate? Well, the main muscle that elevates the palate is the levator veli palatini, and it's innervated by the vagus. So if the right vagus is damaged, the left side of the palate will elevate normally, but the right side will kind of sag, and that means that the uvula deviates to the left. So with a vagus lesion, the uvula will deviate to the side opposite the vagus lesion. And the next question says, a patient's uvula deviates to the right when she says ah. What neurological structures might be damaged? I recommend working backward on this type of question. Rightward deviation of the uvula means that the muscles in the right palate are raising the palate, but the muscles of the left palate are not. So, what innervates the left soft palate? Well, it's the left vagus nerve. And most of the motor neurons of the vagus nerve originate in the nucleus ambiguus, in the medulla. So a left nucleus ambiguus lesion could also do this. Now when you hear nucleus ambiguus, I want you to think of two very specific functions, swallowing and speech. So the functions of the nucleus ambiguus aren't very ambiguous. They're very specific, swallowing and speech. I always thought it was kind of funny that the vagus nerve contains neurons from the nucleus ambiguus. Can't really make that stuff up. Now, what about a cortical lesion? Well, the nucleus ambiguus receives input from the motor cortices on both sides via the corticobulbar tracts. So a lesion above the nucleus ambiguus won't necessarily cause the uvula to deviate. There are just a couple more cranial nerves which are found in a separate table. Cranial nerve 11 is the accessory nerve, or the spinal accessory nerve. It provides motor innervation to the sternocleidomastoid muscle and the trapezius, so you can test cranial nerve 11 by having the patient turn his head against resistance and shrug the shoulders against resistance. And that brings us finally to cranial nerve 12, which is the hypoglossal nerve. It exits the skull through the hypoglossal canal, which is pretty easy to remember. And of course, since glossal means tongue, it's also easy to remember that the hypoglossal nerve provides motor innervation to the intrinsic muscles of the tongue. And to test the tongue, you ask the patient to stick out his tongue and make sure it sticks out straight. The next question of the study guide says, if the right hypoglossal nerve or nucleus is damaged, to which side will the tongue deviate when sticking out? Well, remember we said with a vagus nerve lesion, the uvula will deviate away from the lesion. But the hypoglossal nerve is a little bit different. With a right hypoglossal nerve injury, the muscles on the working side, in this case the left side, will push the tongue forward. But the muscles on the injured side are weak. So the tongue deviates toward the side of the lesion, in this case toward the right side. So you can remember that for the hypoglossal nerve, the tongue licks the lesions. Remember those L's. Hypoglossal nerves lick the lesion. And again, with a cortical lesion, you usually won't see tongue deviation because the cortex projects to both hypoglossal nuclei. And now it's time for the end of session quiz. So pause the video and answer those questions, then restart the video and we'll go over the answers together. First question, what two nerves are tested with the gag reflex? Remember, that's cranial nerve 9 and 10. Next question, a 19-year-old man presents with a furuncle on his philtrum and the cavernous sinus becomes infected. So what neurological deficits might you see in this patient? So remember, cranial nerves 3, 4, and 6 all pass through the cavernous sinus, so this can cause varying degrees of ophthalmoplegia. For example, with the cranial nerve 3 lesion, the eye is going to point down and out. With the cranial nerve 6 lesion, the eye won't be able to abduct. And then ophthalmoplegia is actually going to present very often with double vision or diplopia. And also, since cranial nerve 5 passes through the cavernous sinus, an infection could lead to pain or numbness on the upper face. And our last question, how can a stroke of the facial motor cortex be distinguished from Bell's palsy? So remember, a stroke of the facial motor cortex will result in contralateral paralysis of the lower face, but the eyebrows and the forehead will be spared with a stroke. Bell's palsy causes paralysis of both the upper and lower face. So that's it for the cranial nerves. I'll see you next time.
These two guys don't get along, but when it comes to education, they are never wrong. Yeah, if you pay attention, you might get an A. They don't like each other, but that's okay, 'cause they are bosom buddies.
Hello, and welcome to another episode of Bosom Buddies. I'm Dr. McInnes, and unfortunately, with me again is Dr. Lewis.
Hello.
So, today I wanted to talk about the tongue.
Whoa, hold on there. I don't think I want to discuss the tongue with you.
Why not?
It makes me uncomfortable.
Why would talking about tongues make you uncomfortable?
I don't think you and tongues go very well together.
What are you talking about? I have a tongue.
Please don't remind me. Now I have your tongue burned into my brain.
Go lick a battery. Let me teach something. Okay, so a classic question you'll often get is what nerves innervate the tongue for motor and taste? Motor innervation is from the hypoglossal nerve, cranial nerve 12. Taste sensation is mainly from cranial nerve 7 in the anterior 2/3 and from cranial nerve 9 in the posterior third. And then a tiny bit of taste sensation in the extreme posterior of the tongue is from cranial nerve 10. That's it. What'd you think?
I'm tongue-tied.
Hilarious.
Really?
No, that was terrible.
Can we stop talking about tongues now? I feel a little nauseated.
Yeah. Goodbye, everyone.
Bye.